Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and the entire tri-state community. We have a wonderful show tonight. We have wonderful guests, and we're going to talk about specialized care. So many of us think about when you go to the hospital, does that hospital specialize in this procedure, specialize in this kind of intensive care unit, specialize in this kind of disease or process? So we're going to talk to two wonderful experts in this field. I want to introduce Dr. Nfonoyim, a good friend of mine and a wonderful guest on the show who's been here before, who's the director of the intensive care unit at Richmond University Medical Center, and Dr. Jennifer Musumeci, I hope I said it right, who's one of the chief residents. And we'll talk about what a chief resident is in a few minutes at Richmond University Medical Center. So we're going to jump right in. Richmond University Medical Center, which I'm the chief of neurology at, and really a pleasure to be at, and a wonderful hospital, just opened up a new intensive care unit. So let's talk about the intensive care unit, and then we'll talk about my unit a little bit more, a little bit later about strokes. So tell us, what's the training of the director of the intensive care unit?
The training of the director of the intensive care unit, usually you have to finish a primary residency. That can be in medicine in my case, or in surgery, anesthesia, pediatrics, and then you do a fellowship in critical care, where you basically you're trained to diagnose, manage, treat life-threatening conditions for patients that are in the hospital. You basically are the one who takes care of the sickest of the sick patients in every hospital. So that training prepares you for that.
And of course,
as far as the administrative aspect is concerned, the administrative courses you can take. A lot of us have master's degrees in management to help you with that.
You need that to manage a lot of people. And of course, you start off as being a medical doctor.
Yeah.
So Jennifer, if you could tell us a little bit, you're chief resident at the hospital, and you help get people to the right places at the right time to man the place 24 hours a day. Mm-hmm. Tell us a little bit about the intensive care unit for you. Really meaning, what do you think about when you guys are assigned to be in the intensive care unit?
I think at first everyone's very nervous because, like Dr. Nfonoyim had said, you are handling the sickest patients that are in the hospital, but we are given a large amount of support just by the staff that's there alone. It's one of the best places to learn. As far as teaching is concerned, we do full rounds and everyone's heavily involved. Our respiratory therapists, our nurses, you can learn from pretty much anyone that walks in there. So it gives, a great sense of safety in a place that, overall feels so scary to, someone who's learning how to be a doctor.
So do you tell us something about the team? I mean, Jennifer was mentioning number of members of the team, but tell me how important is the team?
And the team is extremely important. You have your physicians, you have nurses, you have the respiratory therapists, you have the dietitians, you have the pharmacists. The important thing is, every individual brings a certain aspect from their training to the care of a patient, to make the care of that patient whole. The pharmacist is there, he or she's done so many years of training. You as a physician, you've done so many years of diagnosing and managing patients. So you all have a conversation when you're talking about the patient, and you get an input from everybody, including the nurses and the dietitian. So that does help. The communication with one another definitely helps.
What makes an intensive care unit an intensive care unit?
What makes an intensive care unit is the location, obviously, then the amount of monitoring that is being done in those areas, the patients that have been managed in that particular area, and the type of interventions that are done in that area. As I had mentioned earlier, the sick patients, that's where they go. So there has to be very close monitoring, and with the monitoring, there has to be intense, a quick intervention if it's needed. As they say in critical care, right diagnosis right now, right care right now. So you want to make sure everything is done very quickly. That's what makes it.
So it's a higher level of care, and also clearly the nursing ratios are different. So there's intensive care unit ratios. I think that's one nurse for every two patients.
Right.
I run the stroke portion of our intensive care division, and we have one nurse for every 4 patients.
Right.
And unless if someone is sicker, we sometimes have that nurse take care of 2 or 3 also. So the idea of why patients do better, of course, because of the rapid interventions, more that we could do.
Yeah.
But the nursing care, it seems to be one of the critical aspects of why people do better in intensive care units, in stroke units where patients have had an acute stroke. And really just for the viewers out there, what a stroke is when a part of the brain doesn't get enough oxygen. There's bleeding strokes when it's almost like a pipe that burst, or you can get an ischemic stroke where there's not enough blood supply going because there's a clot or something else that prevents the blood flow. And that leaves people with focal or neurological deficits like speech problems and weakness on one side or the other. So the idea is you say to yourself, why would someone do better in one of these units, is the nurses are trained to recognize change.
Definitely. Nurses are they have special training, they have special certification, which they keep on every year. There's so much that they have to learn in order to maintain their certification to be in those units. And they know how. The thing is, when these patients come in, what is happened, where complications do happen, and the nurses who are trained to take care of these patients are very good at picking up those changes and making sure everybody knows so that interventions can be done on time.
So Jim, from a resident point of view, tell us about your interactions with the nurses, and actually even the number of doctors that are in the unit. You know, there are different places in the hospital. You'll sometimes go up and you'll see someone's allowed to have lunch, dinner, make a phone call, but you don't have that in the intensive care unit. That's where the guys and gals actually have their food brought up to them, and they're sitting there the whole time. So it's a whole different feeling that you get. So tell us a little bit about that.
So like the nurses, the number of patients to residents that we have as well is also decreased. So residents are responsible for a lesser amount of patients because of how critically ill they are. But the time spent and, you know, the management of your patients, like you said, you know, large part of your day, although you have less patients, it's heavier workload. You're in direct contact with the patient more often, you know, involved in more complicated even procedures, and the nurses really guide you and help you throughout the day. You know, it's like a system of checks and balances. As he was saying before, our pharmacists, our nurses, our respiratory therapists, you know, everybody's constantly in and out of those rooms, so it's easier to catch things, you know, for your
Let me break that up a little bit. I mean, because we know what each one of these people do. We're sort of talking about the nurses monitoring for change, seeing if there's any complications, trying to avoid medical complications or problems that could occur. Back to the stroke unit, we don't want our patients getting pneumonia. We don't want them having urinary tract infections. We don't want them getting bed sores. Things that hopefully can be avoided, infections of various types. So tell us, let's go over to the different people who do rounds. So when we go on rounds, you know, it's always impressive to families and when even just anybody walking in to see how many people are on rounds. And there's always the technical aspect, and that's what's so wonderful about the new unit, which we'll talk about in a few minutes. Like you have to press all the buttons, get all the pictures up, and get everything together. So let's talk, what does the respiratory therapist add? What part do they deal with?
So respiratory therapists, especially in the ICU, they work closely with the kind of ventilation that the patient is receiving.
So a lot of patients in the ICU are on respirators.
Right. If not, they're requiring, you know, less invasive measures like a BiPAP or a CPAP machine.
Tell us a little bit what that means.
So our more invasive measures would be someone who's intubated requiring a machine that they're connected to help them breathe. A lesser invasive strategy would be like a mask or, you know, nasal cannula oxygen, depending on the requirement of the oxygen that the patient is requiring. So the respiratory therapist helps you adjust to the needs of the patient. They can go over the settings with you in regards to how to better the patient or upgrade or downgrade the amount of oxygen that the patient needs.
And I'll never forget, I don't know if Jay, you have the same story. I'll never forget when I first became a resident, and I was trained out on Staten Island, and I trained at Columbia. The first day you walk into the ICU, everyone's very nervous. And the first thing, and the nurses know that you're nervous. And the nurses actually could almost run the place by themselves in a lot of ways. They don't, thank God, but they know they can. So the first day they come out and they say, doctor, which is a little strange even for some of the first year interns who just became physicians. There's always that story where we have a patient who's having a problem. What would you like to do? and you look at yourself and you have your book out in front of you and you ask the nurse, who looks very, very confident, what do you think we should do? Now, of course, there's much more, and from the time when I trained and when Jay trained, there's a lot more supervision, especially early on, and that's a great thing. That residents, don't run the place themselves. These are clearly all under the supervision of intensivists who are often who are usually in the hospital. So things are very different than they were. But back then, it was the idea that if a nurse said to you, I think you should look at this medicine, or try this, or look at that, you'd say, I think you're right. And then quickly you look it up in the book and see if it is right. And you know what? They always were right. Yeah, so that was the important part.
They've seen it enough.
So let's talk about pharmacy.
Yeah.
So people listening are saying to themselves, what is a pharmacist? I go to CVS, I get my medicine. Yeah. But the idea about drug interactions, and we use a very fancy word called reconciliation, trying to figure out if everyone's on the right medicine. And no matter how smart you are, if someone's on 8, 10 plus medicines, the interactions between the two can be life-threatening. So tell us a little about how the pharmacist helps.
So pharmacy, it's actually kind of amazing. You put in an order and maybe 20 seconds later you'll get a phone call about whatever it is that if they've caught. But it's also part of a learning process for us as well, because some interactions that we haven't read about or are less common, and you are in the ICU, you are using different medications that you don't use in typical everyday outpatient life. So they help go over certain interactions and why they're happening. So normally if you put in an order and you realize that there's an interaction, you are more prepared for the next time you place that order, and it's something that you end up looking for. Whether the patient has an allergic reaction, an allergy to a medication, if there's a cross reaction with another medication, or even if just two medications like combined that you're prescribing to the patient interact, the pharmacist always goes over it with you and kind of checks to make sure that this is what you intend to use it for, if it's okay to monitor the patient with it versus trying to prescribe something else.
Tell us about the new ICU. So you should be very proud of it. I mean, the whole hospital is so proud of all the work that you put in, really, to get this up to as state of the art as you can imagine. So if a family comes, and maybe we're going to start a little bit before. How does someone get to the ICU? What criteria do people have? Because if I was going into the emergency room and I was silly enough to go there because my nose itched. And I'd like to have a nursing ratio of 2 to 1. I'd like to have everybody really on top of me, as my family would say, because I really need. I'm a high need person. I need to be taken care of. So tell me, how would somebody get to the ICU? What criteria do we need?
Yeah, it simply is the amount of monitoring that you need.
And give us some examples.
Yeah, I'll give you an example. If you came in with, you can't breathe, and I'm going to give you oxygen, as Jen mentioned earlier, if it's a nasal cannula, maybe not, but if you're going to have a BiPAP, a CPAP machine, or a ventilator, you need to be in a place where you need to be monitored very closely. So you need to be in the ICU for that. And if you are not on a machine, not on a ventilator, and there's a possibility that you might, we want to put you in a place where we can monitor you so closely, so that if you do need to get on a machine, as I mentioned earlier, it'll be done immediately for you. If you walked in and you came in with a bleed, we're worried about what is going to happen within the next 2, 3, 4 hours. So you have to be in an ICU where we can monitor and get interventions.
Blood pressure support.
Blood pressure support. If your blood pressure is very low, and we're trying to get that blood pressure up, we need you to be in a place where that can be done.
And the neurologist patients who are in a coma, whether it's because they overdosed on medicine, on some drug, or whether they have bleeding in the brain, or they've had a stroke. The idea that we have people watching patients that closely. So those are some of the criteria. If someone comes into the emergency room and they have very, very significant problems breathing, if their blood pressure is not stable, if they are not awake and alert, meaning that you can't care for yourself. If you're not awake and alert, you're worried that things will go down the wrong pipe into the trachea and the lungs. So those are the people. So let's jump ahead to what we really are so proud of. Let's talk about our new ICU.
I'll tell you about the new ICU. I'm really excited to talk about the new ICU. I will say I've traveled quite a bit. At my age, I think I should. But I tell you, I have not seen an ICU like the one we have at Ramsey. The rooms are like suites. it was built in such a way that you have the patient in mind and you have the family in mind. And I think we got to this because before the construction, we just come through COVID, where family wasn't there, and we really missed family during that time. And when they're doing the construction, say family has to be included here. So they are built like suites. The equipment in there is state of the art. Besides the unit being the state of the art construction, the equipment is state of the art as well. And I would want to mention the fact that we learned a lot from COVID as well. If you walk into that ICU, it has 14 beds. But it's been made in such a way that if we do have another pandemic, hopefully we don't, you can double the size, the capacity of the unit.
And what impressed me the first time I walked in, of course it was beautiful, all the state of the art, were the beds and for the family.
Yeah.
So we use the word suite, but maybe say there's a bed for a patient, and there's actually a little living area for a family in each room.
You're right. Living area, showers, and all. It's like an apartment. Let me put it that way.
And how about the state-of-the-art monitoring? I mean, I remember seeing you over the last few weeks in the ICU.
Yeah.
So tell me about the monitoring in the unit.
So the unit itself requires, specific things that we look for, whether it's the oxygen that we're checking for the patient, the type of rhythm that the patient is having currently.
So, and again, even when you say like an EKG was running all the time on a monitor,
Right.
People are much familiar with COVID with those pulse oximeters.
Absolutely.
And different ways to monitor oxygen.
And the way that the rooms in itself are set up is that you can easily see into each patient's room, even for visual monitoring, as opposed, to being on the general medical floors where, it's harder to take a glimpse at each patient that's there. So, nurses' stations are set up directly across from, patient's room with computers that are dedicated to that room itself. So it's easy access for the residents and whatever staff that's there to watch the patients.
Any procedures that are being done there? A lot of people think about the ICU, of course, we're watching patients. So we're watching them, we're watching their oxygenation, we can give them more oxygen, we find their blood pressure, we can increase their blood pressure control. A lot of patients are on sedation or medicines that make them not be as agitated because they're in this uncomfortable situation. But procedure-wise itself, what kind of procedures can get done now that we might not have been able to do before?
I mean, right now, besides doing procedures or resuscitation, like putting in special lines, putting the patients on the ventilator, you have enough room there that if you had an emergency to do even a cesarean section, that could be done. There's enough room, there's enough lighting. The team just has to get there. If you need to get into somebody's chest to put in a chest
It's almost emergency surgery type things.
You could do that in those rooms.
Marvelous. So in your heart of hearts, do you think people are going to survive their stay that might not have survived their stay? Not in our old ICU, but in other older ICUs. Do you think it's really going to translate? I know patient comfort is crucial, family comfort is crucial. Do you think it's actually going to save people's lives?
I mean, I'll go back to the old ICU. We did the best that we could. The outcomes were very good. But whatever I do, it can always get better. And the new ICU, just the fact that you can see all the patients, there are monitors in the rooms that you can see the patients from the desk. You have that's seeing the patients in bed, and you have their cardiac monitors and their pulse oximetry. As I said, monitoring is the most important thing. If you can get that information, you can intervene. And now that we can get that very easily, we'll be able to intervene faster, and I'm sure with that, you'll be able to improve your outcomes.
Tell us about infections. I mean, you've always made, since I've known you, the idea about various intravenous lines, whether it's in your hands or centrally, there's a risk of infection. Do you feel, and again, I know you've really spearheaded this at our hospital, the idea of how to reduce that, because that could be a life-threatening event in someone who's medically ill. Do you think a new ICU, and again, there's always germs everywhere, so no matter how new everything is, it still can happen. Tell us a little about your training with regard to preventing infections. And do you think that having this kind of setup will help reduce it. So tell us, Jen, about it.
So anytime we do any kind of procedure, whether it's just drawing blood, placing a regular IV line or a more invasive IV line, the first thing we're always taught is about, sterility and, even basic techniques of hand washing. So, our rooms are large enough for us to set up, properly and, give us more room so we can maintain a sterile field and make sure that the patient is getting whatever it is that they need. But always, before the ICU we have now, our old one, the technique and how we place the procedure is always, how we place any kind of IV line or any kind of procedure we do is always emphasized.
Good, tell me, Jen.
And then the other thing, if you walk into the ICU, you realize there are no curtains, because the curtains increase the chances of infection. So you don't have any curtains in the ICU. All you do right now is you get your shades, you press a button, and the room shades up, it closes, there's privacy for the patient. So that does help. And the fact that you have patients in single rooms, you don't have the risk of infection from one patient to the other, besides making sure everything that is done in a sterile fashion. We'll make sure their urinary catheters don't stay in any longer than they should. The lines that are put in for resuscitation come out soon after the patient is resuscitated. All those things do help with reducing infection.
And that reduces the length of time in the hospital. That makes patients have a much better chance of going home.
Yeah.
So we're going to jump ahead to stroke. And to all of us, stroke is a medical emergency. I've mentioned before that patients get strokes for a number of reasons. There are strokes in younger patients, people who have sickle cell anemia or congenital reasons to have thick blood or hypocoagulopathy, we say. Patients who are older who have atherosclerotic disease or heart disease that can cause a stroke. But once someone has a stroke and they come to the emergency room, interestingly enough, years ago, patients with stroke were just, okay, you had a stroke. And you would sit there and people would take care of you, but you wouldn't be rushed to the front of the line. People who had heart attacks were rushed to the front of the line because they were interventions. With stroke, we now have interventions. We've got clot busters, namely something called TPA, and a new one called TNK, which we're going to start using a lot more of.
Right.
And the idea of, and also we have a very good team that does something called thrombectomies. You can go in and pull out the clot. So really, our neurology is about 2 decades behind cardiology, the heart doctors, and how we're able to get things out and be more involved. But over the years, we've learned, and it's interesting that it's the American Heart Association, National Stroke Association merged really with this, that having people in specialized units do better. And for running a stroke unit at one hospital out in Staten Island, now director of the stroke unit at this at Rumsford University for the last 15 years. The idea of what we're seeing with regard to stroke care has so dramatically changed that patients are doing better. And you round there every day, I round there every day. Jen has actually manned the place. The idea, so what do you think when you see our stroke patients? And I just can't tell you how impressed I am with my nurses, with our nurses. I walk in there, and if they're not even have a chance to take my coat off. I can't even sit down. I get one of these, and I say, the patient over here, we'll say Mrs. X, Mr. X, is having a problem. I noticed it when I came in at 8 o'clock. You're here now. I want us to address this right now. And instead of this becoming, well, I'll get back to there in an hour or two, no, we're very much on top of this. So the residents are there all the time also. It's part of the intensive care unit team. So tell me, what are your feelings about stroke units as a whole?
I mean, they're very important, even if, someone comes in with stroke symptoms, but maybe at first, they resolve or imaging is not showing that, as of yet. So they're important in monitoring the patient in general to make sure that we don't miss something else that's going to happen. So my experience in being there, things won't get missed as much as because of the nursing ratio, because of, there's a resident that's always close by, they have less patients to take care of. I think that's what makes it, so great to have a patient in that setting. The access to getting the patient different kinds of imaging quicker, as opposed to
CAT scans and MRIs and things like that.
So these patients do take a priority because, we can prevent something, that's, really will change a patient's life, deficits like you were talking before, whether they're focal neurological deficits.
And as you said, I think that's a wonderful point. There's a term called TIA, or it's not really a mini stroke, but it's a transient event, and it goes away. And the highest risk after someone has had a stroke or a TIA of having another stroke is actually in the next few days. So the idea that we're able to monitor someone's blood pressure, give them very strong antiplatelet agents, or which means blood thinners, or anticoagulants, which is another form of blood thinners, in order to make the proper diagnosis. Interestingly enough, and I think we're going to do a show about this next month, is that a lot of people who have stroke that we never know why they have stroke turn out to have what's called atrial fibrillation. And everybody's probably familiar with this because you keep on hearing about it on television, is that irregular heartbeat that people have, which increases the risk of stroke at least about 5 to 7 times. And there are blood thinners for that really help tremendously. There are actually procedures now available for people who can't tolerate the blood thinners. But the idea that we're able to monitor people's blood pressure, have a nurse really on top of their care, really has changed the way that we see patients with stroke. And it's thrilling for neurology now to be on the forefront of this, where we have interventions, blood pressure interventions, blood thinner interventions, clot busters, thrombectomies, pulling out the clot, and even neurosurgical techniques for stroke that we've never had before in order for patients to do better with a really very ominous and scary diagnosis that we have. So I want to say thank you to you guys. I mean, and again, we have about a minute left. Is there any one story? We went through COVID, and Dr. Nfonoyim, nobody was in the hospital more than you. I mean, I would go in and make rounds and then whatever. And the idea that you were always masked, gowned, the whole outfit there, really saved so many people's lives. Really, it was tremendous. Is there anything you'd like to impart to our audience about your experiences in the ICU and during that hard time?
I tell you, it was a very challenging time for everybody. And I'm happy we went through it, but to be able to get patients, some patients come back. As a matter of fact, I'm happy you didn't ask. I had a young lady who came in, was delivered emergently, came to the ICU, was there for a protracted length of time, had a tracheostomy done, was on a ventilator. She came back last week. It was last week, right?
I think so.
Yeah, last week for her anniversary to come see us in the ICU.
Oh, how beautiful.
Yeah, so I cannot forget that. I can't forget that young lady. Just seeing her lying there, having a baby, couldn't see the baby, and here she was walking in.
And even in the stroke side, people who we've taken out the clots and they come back to visit us. It's really been such a wonderful experience. I'm sure even in your relatively young career, you're going to be seeing more and more. And really, it's really the reason we've all become physicians. I want to thank you two. You guys have been wonderful, wonderful guests. I want to thank everyone and really have a wonderful night and really all the virtues of specialized care. Take care. Good night.
Thank you.